It might be more clinically oriented, but it's basically the same. So those who had a hard time understanding French, they might benefit from listening to my talk. Dyspnea, wheezing, and cough are definitely the most common complaints or symptoms in our daily office practice. Are we dealing with asthma or not? Many times we have patients coming to us saying, "Doctor, I have asthma." They might tend to say we have asthma rather than COPD because asthma is something that they got from God, while COPD might be inflicted on themselves from smoking cigarette. But we might be given the diagnosis that I have asthma because a friend might have told them, because a pharmacist might have mentioned it to them, or maybe an emergency physician might have heard some wheezing, or sometimes a family physician might have said, "Definitely, I'm sure you have asthma." Now, from our standpoint, from the specialist standpoint, whether pulmonologist, allergologist, ENT, whether we deal with adults or pediatric patients, we have to make the correct diagnosis. We have to be sure that we are dealing with asthma and not with its imitators. And these can be an acute bronchitis with some airway hyperactivity. It comes just once. Or maybe a recurrent bronchitis. Maybe COPD, as I said, and patients, they don't want to admit that, and they say we have asthma. Vocal cord dysfunction, pulmonary emboli sometimes can present with symptoms that might mimic asthma, bronchiectasis, or any other etiology that can cause cough, rhinosinusitis, postnasal drip, reflux, or medication-induced. So basically, as a specialist, history, detailed history, and history taking is essential in making our diagnosis. Once the diagnosis of asthma is suspected and confirmed by pulmonary function testing that shows reversible airway disease, then for us, for a pulmonologist, and this is the core of my talk, asthma from the pulmonologist standpoint, it's inflammation, inflammation, and inflammation. If we are to be successful in treating asthma, we have to control the inflammation. How? We have to identify the triggerers. These triggers might be flaring up asthma and maintaining them. And there are a growing and growing list from environmental factors, dust mite, food allergens, pets, cockroach, and the list keeps growing and growing. And all of these factors are factors outside our body. We might have factors inside our body from rhinosinusitis, nasal polyps, gastroesophageal reflux, and we shouldn't forget medication-induced asthma. And beside the beta blockers and the aspirin, you do just simple internet search, and you see the list keeps growing and growing and growing. So if we play this fill in the blank, beside the triggering factors, if we are to control asthma, we have to control the inflammation, and this happens by stabilizing all irritable, excitable, inflamed cells to reduce the amount of cytokines and mediators. So usually patients who come to us as specialists, they are more severe than the mild intermittent cases. Usually as specialists, we see patients with persistent asthma, whether mild, moderate, or severe. And these patients, the main drug is steroid. It's the backbone, is the principal medication. Whether it's oral or inhalation, we have to control the inflammation. Yes, we have guidelines to help us step up the treatment, but not much to step down the treatment. We can follow the guidelines. Guidelines are put to back us up legally if something happens. So we must know the guidelines, and we should try to abide to the guidelines as much as we can. But we know that guidelines are lines to guide us. We are allowed to move away from the guidelines if we can justify our thinking, if we know our patients, and this is what makes medicine an art, after all. So once we use the steroids to control the inflammation, we have more medications to add. We have them as anti-inflammatory steroids and leukotriene modifiers. We have the forgotten drugs, the mast cell stabilizer, cromolyn, nidocromil. Yes, they are forgotten. We have bronchodilators, whether short-acting, long-acting. Now we have the ultra-long-acting beta-2 agonist. Yes, it's for COPD. But wait a couple of years, you're going to have studies coming up saying that it is also good for asthma. Why not? Anticholinergics, they're not for asthma, but poorly controlled asthma on a chronic basis, it can become chronic bronchitis / COPD. Why not? Theophylline, our colleague was asking, it goes like a pendulum, back and forth, back and forth. Now we have phosphodiesterase E4 antagonists, which they don't like to mention. It's a methylxanthine. It's not. It's for COPD. But why not for asthma? Let's wait, and we'll see the studies a couple of years down the line. Then we have the monoclonal antibodies, anti-IgE. So with all these medications in our armamentarium in fighting asthma, if we're still losing our fight to control the inflammation, we must consider other factors. Basically, non-compliance, poor technique, the cost of the medications, this is in Lebanon, and poor quality of medications. Unfortunately, it might be everywhere, but maybe in Lebanon. So if we suspect poor compliance, make sure that patient education is done on every visit. Poor technique, we need to observe our patient using the inhalers in our office. Cost of the medication, it is a problem we cannot ignore. And the quality of the medications, especially in Lebanon, we have an open country. We have to control, we have to deal with it on a daily basis. Now, we shouldn't forget other conditions that are associated with asthma. And these can be acute or chronic, whether it's a GERD or it's just a reflux that starts because of the cough and the cough and the cough. It has its own list of medication. The rhinosinusitis, again, whether it's acute or chronic, it has its own medication. And medication-induced asthma. Patients might come to us saying, I've been on this medication for years. Why now it's causing my symptoms? Well, it's always puzzling, and it's a diagnosis of exclusion, but certainly we have to consider it. And we should not forget autoimmune disorders, where we can get serology, IgE, eosinophil, parasites, and biopsies, whether bronchoscopy, mediastinoscopy. And I mean by that, if you look at the list of the asthma differential diagnosis, we can see, for example, Churg-Strauss disease, we can see sarcoidosis, we can see other elements where serology, biopsy might be needed to make to differentiate asthma from its imitators. Now, to wrap up the whole discussion, beside all the medication and all what I've been talking about, we know that all pulmonologists, they master asthma. We know it. It's in the books. It's in our daily practice, our bread and butter, and we all know what asthma is. But from the pulmonologist standpoint, practicing in this country, the cost of the medication, even if we are practicing in a high socioeconomical status area, it's really difficult for someone who's been well controlled to just buy medication and put more medication in his system or her system when he or she feels great. So patient compliance and the cost of the medication is an issue. And many times patients have no access to healthcare facilities. They cannot go to the emergency room, or they have no access to their doctors. And they say, we tried to call our doctor, we ended up in another office where the medications are changed, and they blame it on that. At this stage, I was timing myself for 15 minutes. I said, let me open the room for questions, this time in English, another 5 minutes, and then I leave the stage for our colleague allergologist.